topic. So therefore, let's not waste time. And with the permission of the chair, I would start sharing the screen. I hope it's clear.
Sir.
Okay. So today we'll be talking about some advanced communication procedures. I purposefully call it procedures because as medical professionals, we have to understand that when we are communicating with our patients, there is a indication for that. There is usually a structure to it. There's a SOP, and there is an expected outcome. So just like any of the uh, our medical interventions, it is a procedure. And today we'll be covering about bad news, how to communicate bad news. Essentially, it is just truth telling. Many times I have encountered this query that, should we convey bad news? If I counter it with the question, should we convey the truth? So then that puts it into a different perspective. So essentially, conveying bad news is basically conveying the truth. It is truth telling by another name. There we will talk about the various models and the issues related to it. We'll also talk about why it is important to communicate bad news, the rationale behind it. We'll also, from there, we will take a deviation to another topic, which is collusion. We'll spend a couple of slides on that. Then we will come back to communicating bad news, but this time we will talk about how to communicate the SOP, the spikes protocol, and we will indulge in a bit of a role play. I will not make any of you uncomfortable, so it is just sit back and relax, and we will have a role play nevertheless. And the last part, we will talk about managing anger in our clinical situation. So as I said earlier, communicating bad news is nothing but telling the truth. And oftentimes, truth telling is difficult, it is not easy. And therefore, we rather not do it. But in our profession, we invariably have to do it. Doesn't matter what specialty we are working in. We have to eventually convey. And you as pulmonologists will be dealing with many of the situations like advanced COPD, interstitial lung disease, or malignance or cancers. So a lot of areas for you as pulmonologists to talk about the truth. Most of the time, we, especially in the Oriental culture, that is the Asian culture, we do not tell the bad news to the patient. Even if the patient has come with the family, we often ask the patient to go out of the room and we talk about the diagnosis and prognosis with the family, and the patient just waits outside. So this model of not disclosing to the patient is a non-disclosure model. We may have our reasons for practicing non-disclosure model. It may be the prevalent form of practicing communicating bad news. We may think that we are trying to protect the patient in some way. We may have our own reasons. The problem is, what if the patient wants to know? The patient may have many reasons for wanting to know. And hence, this non-disclosure model gets into the conflict, gets into a conflict with the patient's right to know. In some places, a full disclosure model is practiced whereby the patient is told about the truth, the full truth, and often you need the patient's permission to talk to the family. There are many countries, many of the developed countries, if I may put it that way, where full disclosure model is practiced because often the patient's autonomy is held to be sacred. In our culture, the patient's autonomy is usually subservient to the family's right over the individual. So individual rights is one step below the family's right or the community's right. So in our culture, the patient's autonomy is not as sacred as it is in some other cultures. So where the patient's autonomy is held sacred, full disclosure model is practiced. That is, the patient is told everything. Now, this model also has a problem. What if the patient does not want to know? There might be a patient like that. And if our regular practice is full disclosure, what will happen if we do it with somebody who does not want to know? So this model also has a problem. It can get into conflict with the patient's right not to know. Therefore, what do? We have to figure out a disclosure model which will suit the individual sitting in front of you. And that would be the individualized disclosure model. Essentially, what that means is we have to first figure out whether the person sitting in front of you wants to know or not. And once we have figured that out, then we have to proceed only with a person who wants to know. And then the next thing that we have to figure out is how much does the person want? Does the person want to know 100%, 75%, 62.8%, 30.4%? Whatever it is, we have to figure out how much the patient wants to know and give only that much information, not less, not more, just the optimum for that individual. So this in sum total would be the individualized disclosure model. Now coming to the rationale of communicating bad news, why it is important to communicate bad news to a person who wants to know, not to somebody who does not want to know. For one, it helps a person finish off the unfinished things that the person has in life. Remember, majority of the people die slowly. There are some studies which say less than 10% of the population has a sudden death. So you and I are more likely to die slowly. So when we are in that situation, if somebody tells us, only then we will think, okay, if this is the situation, then while I am physically healthy, while my brain is still working, there are things to do. It may be related to finance, it may be related to writing a will, it may be giving instructions to your spouse, your children. It may be about trying, doing things that you always wanted to do. For example, a bucket list or making memories, going out and, basically create memories for yourself and your family. It's also time to strengthen the relationships and also to mend broken relationship. What if you had a friend with whom you had a fight and now you haven't talked to that person for 20 odd years? Maybe I would pick up a phone and pick up, the phone and call that person and say, this is the situation. I wish we could meet. It's a time to ask forgiveness for whatever you may have done. It is also time to forgive. for people who have hurt you. So there's a lot of things that can be done, provided you know that your time is limited. Theoretically, we all know that our time is limited, but in our day-to-day life, we don't live like that till somebody tells us that we have an incurable, progressive, advanced medical condition. It also prevents hospital hopping and doctor shopping. Oftentimes, we see that a patient uh, may have reached us after going to various other places. What happens is the family may have been told the truth, but the patient does not know. And because the patient does not know, the patient expects to be, back to normal life, because everybody has to get back to normal life. So patient's expectation, according to patient, may be realistic, but according to rest of us, including the family, are unrealistic. So the patient having unrealistic expectation is definitely not the fault of the patient. It is just because nobody told the patient the truth. So patient does not know the reality. And because of this, despite your best efforts, the patient will eventually lose faith in you, because the patient is not satisfied. And why is the patient not satisfied? Because you are not able to meet the patient's expectation. And why you are not able to meet the patient's expectation? Because the patients have unrealistic expectation. So the expectation reality mismatch will lead to the patient getting disillusioned with what you are offering, and then will go to some other place. And the family is forced to take this patient from place to place, looking for a cure that does not exist. In the process, they slip into poverty. They lose everything. Their family is literally on the road by the time patient dies. And in a way, we are contributing in some ways we are contributing to the poverty and destitution in this country. Therefore, it is important to communicate bad news. Another reason, and the last reason that I put forth in front of you, it denies people a chance to have relationship. Because when the patient does not know, the family is forced to play a drama in the house, put on a mask of everything is normal, and then act as if everything is normal. And when the family members get overwhelmed, they will go into the father's room and cry, and then wash their face and come back in front of the patient and again continue this drama. Or they may come to your clinic or my clinic and they'll cry their heart out, but they will never be able to cry in front of the patient. So we are denying them, the family, an opportunity to cry and have a real relationship. And we kind of, because we did not make that effort, the drama continues and the patient eventually dies. And then you put a garland around the picture and wish if we had only some more time. So what were you doing when the person was there? That time we were playing a drama. So a chance, only if the truth was told, there was a chance to have real relationship. There was a chance to strengthen relationship. There was a chance to have memories. And all of these things are so precious when life itself is very little available. Therefore, it is very important to communicate bad news. Also, if you think at it from the patient's point of view, we are denying the patient also a chance to have a real relationship. Remember, relationship does not mean always laughing and having a picnic. Crying and hugging your loved one and saying, I love you and I'm going to miss you, is also part and parcel of any life or any relationship. And just because we do not take that effort to communicate the truth, these things. So essentially, 3 points in front of you: closure of life's business, preventing hospital hopping and doctor shopping, and reducing barriers in relationship. Now, even if we want to do this, sometimes the family does not want us to communicate the truth. They will come and tell us, please don't tell it to the patient. Basically, they are trying to enter into a conspiracy of silence with us, saying, Doctor, you tell us the truth, but don't tell the truth to the patient. So, this attempt of a conspiracy of entering into a conspiracy of silence between two parties to keep the third party out is collusion. And this happens very, very often. And I'm sure you would have had personal experiences as well. Now, why do you think this happens? The family does not have a malintention. In fact, just the opposite. They want to protect their loved one, the patient, from harm. From their point of view, we are the source of the truth and they need our services. At the same time, they are scared we may inadvertently tell the bad news to the loved ones. And that's why they come to us and say, please don't tell. Because they may believe that if their loved one knows the truth, it will damage them, it will hurt them, or it will probably cause them to die immediately or early. Now, from the scientific point of view, we may disagree. But remember, for people, their beliefs are real. Whatever their beliefs are, it is real for them. And if we challenge their belief, hey, no, this is nothing, you're just, these are just thoughts in your head, these are things that happens only in movies. So thing is, when you challenge their belief, you only end up increasing their anxiety. Remember, in palliative care, we talk about relieving the suffering of the patient and family. So here, please understand the family is suffering. They are anxious. They are scared. So the first important thing is do not challenge their belief and in fact agree to collude because we want the anxiety of the family to come down. Because in any case, you cannot tell the truth to the family we cannot tell the truth to the patient without the family being on our side. Because if we tell the truth to the patient without the family's permission, we are going to get into major trouble with them. So the first step of managing collusion is to agree to collude. Because when you say, okay, I will not tell, their anxiety comes down. That doesn't mean they have started trusting you, just that their anxiety comes down. Now, we have some time to earn the family's trust. Primarily, three things: listen to the family, listen to what their concerns are, listen to what the story is, just try to listen to what they have to say. Listening helps build trust. And active listening, all the things that we learned during our last session, is all about building relationship. So active listening builds relationship, but that is not enough. All the things that you are learning as part of relieving the patient's suffering, palliating the patient's symptom so that you relieve the suffering, that is going to really get you the trust of the family. So as early as possible, aggressively relieve the patient's symptom, patient's suffering, and then your family, the patient's family will really start trusting you. So it's a mix of everything. Relieve the patient's physical symptoms, build up a relationship with the family, and now they trust you, and now they will start listening to you. Earlier, you were listening to them. Now they will start listening to you because now they trust you. At this point you of the situation, now you can introduce why it is important to communicate bad news. This is the right time. And I'm just giving you the general drift of how we should approach. Individual cases will have to be dealt at the individual level. That, of course, we can't deal with our session today. But once you have earned the trust of the family, then introduce the concept of closure of life's business. The patient will have a chance to do things, to finish off things that he or she would have wanted to. It will prevent unnecessary hospital hopping and doctor shopping, because once the patient knows what is the truth, then the patient will cooperate. And also it will give you all a chance to have real relationship, not fake relationships. Please remember that sometimes the family may not be fully convinced, and as a result may still put up barriers. The collusion may still be there, and as a result you may not get a green signal from the family to convey the truth to the patient. When you're facing something like that, please understand that don't push it beyond a point, because when you push hard, you may be pushed back equally by the family, and all of this will lead to friction and a breakdown of relationship between you and the family. And this is not good, especially for us medical professionals. And definitely it may have an impact on the patient's care as well. So in short, do not make this your agenda that you anyway have to convert the family into thinking that collusion should be done away with. There is no shame in trying and failing. The only shame is in not trying. And you will realize that initially your conversion rates may be poor. But as you persist with it, as your communication skills, the counseling skills improve, you will realize that gradually your conversion rates will improve. That means more and more families you will be able to convince them that it is important to communicate the truth to the patient. In my case, usually when I am able to convince the family, and they sometimes say, doctor, why don't you tell this to the uh, patient? We can't say this. So I tell them, sure, I will talk to the patient, but I will convey only if the patient really wants to know. I will not force the information. So this part also I tell them once the family is, convinced about why it is important to communicate bad news. So that was that as far as collusion is concerned. Now coming back to communicating bad news, all over the world, the SPIKES protocol is the standard operating procedure. SPIKES is the acronym for setting up the interview. P is for perception, basically trying to find out what the patient understands about his or her situation. I is for invitation. Basically, we will communicate bad news only if the patient wants to know, and that is the invitation part. And we will talk about how we go about getting that invitation. And K is for knowledge, the sharing of information. And last time we had mentioned about whatever information we are sharing, we should share in a language that the person understands, and cut out all the medical jargon. Okay. And of course, when you are communicating truth, you can expect emotions. You must expect emotions, and we should know how to deal with it. And once we have dealt with the emotion, then we can get into the rational communication part, which is about strategy. What can we do? What we cannot do? The time frame, etc., etc. So let us talk about a patient. We have Mr. Bharat, who is a 67-year-old gentleman who was diagnosed as interstitial lung disease and has been on treatment since past 25 years. As is to be expected. The disease has been progressive, and since about 1 month, Mr. Bharat has been bedridden with refractory breathlessness. And what happened is lately the patient has not been cooperative with the ongoing treatment. In fact, the patient had a what do you call a friction with this long-standing treating doctor, and decided to uh, go and seek a second opinion from another person, and this another person is happens to be you. So this patient is now admitted under you, ostensibly for better treatment. So this is what you have. So this is basically a referral letter that you have received. This kind of puts in a nutshell about the patient's story, the medical story. Now the patient story, of course, you will talk to the patient, and what the patient tells you when you take a history, a typical history. So the patient tells, I've been breathless since past 25 years. So I've been taking treatment with this pulmonology doctor, and I've been having good treatment all these years. But since past 2 years, the medicine has not been giving any relief. My health is also going down. And since past 2 months, I cannot get up from the bed at all. The moment I try to get up, I have so much of breathlessness, and I'm becoming weaker and weaker. And now the doctor there does not seem to be interested in treating me anymore. So I came here. So this would be a kind of a typical history over here. But when we are taking history, remember last time we talked about history taking 2.0. That means we also need to understand what is the patient's insight. For that, we have to keep asking questions, more and more questions, so that we understand what the patient's understanding is about his or her medical condition. Now that takes a little bit of digging around. And I'll give you an example of how the same history that is there in front of you, we can get more information by digging for more information. So this patient has said, I have been having breathlessness since past 25 years. So I've been taking treatment with this pulmonology doctor. So I may interrupt. So what exactly is your disease? What did they tell you? What my disease is breathlessness. Okay, so your did they mention any specific name? No, no, no. Okay, but I've got good treatment all these years. But since past 2 years, the medicine is not giving me any relief. My health is also going down. Why? What happened? What is your doctor telling you? Nothing. They just tell me to take the medicines. That's all. Okay, then go on. Now, since past 2 months, I cannot even get up from the bed due to my breathlessness. I'm also becoming weaker and weaker. And the doctor there does not seem to be interested in treating me anymore. Why do you say that? Uh, because doctor is not giving me medicines to make me better like before. Okay, so what did they tell you? Well, I decided to come here. So, I want to get better too. So if you ask more probing questions, you will understand what the patient thinks is happening. And you will realize that there are many blank spots in the patient's insight about his or her medical condition. There may be some areas where patient has some correct information, some areas where totally wrong information, and a lot of areas where no information, blank spots. And this is very important because when we talk about telling the truth, we just have to fill in the blanks. And that is how we bring the patient expectation and reality mismatch together. So how do we go about it? So like any preparation, like for any procedure, we have to do a pre-procedure preparation, up to date yourself on the medical condition. And remember, as much as possible, communicating bad news should be taken as an elective procedure. I'm not saying that every time it may be possible. Sometimes you may have to do it as an emergency procedure, but by and large, as much as possible, allocate dedicated time for this, just like you would do for an elective procedure. set the environment. Most of the time, please expect that there will be some crying. So keep some tissue handy, some drinking water, paper cups handy, and whatever we learned last time, active listening skills, keep that also handy. But of course, that is something you will be doing for every patient every time. So we do a little bit of probing. We explore if the patient wants to know. Now, this may not be necessary if a patient comes and says, "Doctor, tell me what is my problem." Then you don't have to explore. But not many patients are bold like that. So sometimes we may have to explore if the patient wants to know. "Mr. Bharat, you told me you continue to feel tired and breathless. Do you wonder why? Do you want to know more about your disease?" "Yeah, yes, I do want to know." "Mr. Bharat, if it is something serious, would you still want to know?" Now, this is very, very important. This is called as a warning shot. Just because a patient says, "Yes, I want to know," does not mean the patient understands the seriousness of the discussion we are trying to get into. Therefore, it is important to give a warning shot. When you give a warning shot, the patient realizes that something serious is going to be discussed. And then you may get a reaction like this: "Oh, I'll take the medicine and then I'll come back after 2 weeks." That means the patient does not really want to know if it is something serious. So tell it to my children. Patient really does not want to know. But the patient may say, "I don't want to know." And most important, look at the body language. No eye contact. When you say, if it is something serious, "Mr. Bharat, and if you do you still want to know?" And if you see no eye contact, then rest assured, even if the person is not saying anything, the patient is staring at the floor or patient is staring out of the window, rest assured this person does not want to know. If there is another patient after warning shot, this person looks into your eyes and says, "Yes, I do want to know." No confusion. Here is a patient who wants to know. So the first criteria of individualized disclosure model: figure out the person in front of you, the individual in front of you, does that individual want to know or does not want to know? So you figure it out by giving a warning shot. There is no confusion. You have very clear, you have absolute clarity about the person sitting in front of you, whether the person wants to know or not. And once you have a person who says, "Yes, I want to know," looks into your eyes and says, "Yes," then you tell a story. You tell the story of the patient to the patient from the beginning of his medical condition. And while you are telling the story, you fill in the blanks with information. And while you are filling the blanks with information, you escalate the information as you go along. Focus on the patient's body language. If the patient stops making eye contact, pause the story then and there. It's possible that the patient is receiving some new information or has received some new information and is trying to process this new information. So maybe the patient forgets to look at you. If the pause, if the eye contact is not there for a long time and it's been a very, very long, uncomfortable pause, you can break the pause by asking the patient, "Should I proceed? Do you want to know more?" Or some statements like that. Then if the patient wants to know more, the patient will look at you and then you can continue the story. If at a certain point of time, the patient does not want to look at you, that means the patient had enough. That is the point you stop the story. So this is how you figure out how much the quantity of information, how much the patient wants to know. So in this way, you will not give overdose of information or underdose of information. And this way you can prevent information toxicity and you can ensure the safety of the patient. So stop where the patient wants to stop. So here I'll do a small role play with Mr. Bharat. And in this case, Mr. Bharat looks me in the eye and says, yes, I want to know. Mr. Bharat, you have been suffering from breathlessness since about 25 years. Initially, your local doctor gave you some medicines, but apparently you had no relief with it. And he did an X-ray also, since you told me that. Well, that X-ray showed something like a shadow, right? And to know more about this shadow, he referred you to the chest specialist, we call it pulmonologist, at the city hospital. So you see here, something like a shadow. You have filled in a blank spot, and in the next line, you have escalated the information. Something like a shadow becomes shadow. It is no longer something like. So you're gradually escalating information. Something like a shadow becomes shadow. Oh, I didn't know that. Well, in the city hospital, a chest scan showed little damage to your lungs. And to know what this damage was, they did the tube test, bronchoscopy, remember? And this was done to get a sample of your lungs to test. This is called biopsy. So if you go back, something like a shadow becomes a shadow, and shadow becomes little damage to the lungs. And in the next line, the little damage becomes damage. It is no longer little. So something like a shadow becomes a shadow becomes a little damage, and then little damage becomes damage. Eye contact is there. We can continue with the story. The biopsy showed that your lungs had a disease called ILD. The full form is interstitial lung disease, but for ease of understanding, it is called ILD. Thing is, it permanently damages the lungs. Are you saying that my disease has no treatment? I'm sorry. Yes, the disease was incurable from the very beginning. Uh, Mr. Bharat, do you want to know more? But all these years, I was taking these medicines and I was okay. Why am I not getting better now? I'm sorry, Mr. Bharat. Not only is the disease incurable, it is also progressive. That means as it progresses to an advanced stage, the regular medicines that have been helping you all this while may not help you beyond a point. Nobody told me anything like this. Nobody told me anything about this. When you have a patient who is ventilating emotion, don't do anything. For God's sake, don't say anything. Just be with the patient. Saying, don't worry, everything will be all right. We are there with you. None of those things is required. They are actually counterproductive. They are just cliches. Just sit silently with the patient. Now, that is something that as doctors, we are not at all going to be comfortable with, because all our training is about doing something all the time. Just this idea of sitting there doing nothing is terrifying for many of us. But that is what is the required thing to do right now. Just be with the patient, because allowing ventilation of emotion is not a waste of time. It is therapy. At best, you can have a gentle touch of the patient for an optimum moment of time and then take your hands off. But just your presence is therapy. Don't start scribbling on the case sheet while the patient is ventilating. Don't look at the computer while the patient is ventilating. Focus 100%. It is like a surgeon who has a bleeder, applies a pressure bandage, and waits till the bleeding stops. The surgeon's full focus is there on the table. Similarly, when you are there and the patient is in this position, focus on the patient, nothing else. Don't say anything, don't do anything. And within a minute or two, the patient would have ventilated the emotion, and then the patient will come back to you. Sometimes you may have a response, an emotional response. Doctor, I'm so scared. Doctor, I'm so worried. Doctor, how much time do I have? So, whenever you have a person asking you something, a red light should go in your head. This is not the point to assume why the patient is saying whatever the patient is saying. This is the time not to assume and ask, why did you say that? And then the patient will say why whatever the patient meant by whatever the patient said. My daughter's marriage is fixed after 6 months. Should I prepone it? So here is a patient who asked, how much time do I have, doctor? Because the patient wanted to plan something. I will give you another scenario. Same question. How much time do I have, doctor? Why do you say that? Or why did you ask that? Why did God do this to me? Now here is a patient who just needs more ventilation. The same question, two people, two different reasons. And if you have 10 people or 100 people, they may say the same thing, but have 100 different reasons for saying the same words. So never assume, always ask. Whenever people say, I'm so scared, I'm so worried, whenever people say something, don't take it at face value, ask. It's as simple as that. And once all the emotion have been drained, now you can talk about what can be done, what cannot be done, where it needs to be done, how much is going to cost, etc., etc., etc. And all of these things we have covered in the last session about participatory decision making, never to give false hope, always to give achievable hope. For example, even though your disease is now advanced, we will ensure that you are always comfortable. Now, this is not difficult. This can be easily done. And we will be always there for you. You can come back to us anytime. So whenever we are closing the interview, always end with a realistic hope. I do it on a day-to-day basis. It is not something, an alien thing. Every day, even today, with one patient and family, I had this conversation. And I can assure you, invariably what they say, doctor, that is all that we wanted to hear. That that you will take care of us. People understand that they are not going to live forever, but they are terrified of suffering. They are even more terrified that they will be abandoned. So we give them this message that we will ensure that they are comfortable and they will never be abandoned. So that is the message we give all the time. And that is the realistic hope we can give. Ensuring there may be limits to cure, but there is no limits to providing comfort and care. Now, this last part is about managing anger in our clinic. Now, I want to just clarify, I'm not talking about managing law and order situation. For example, a mob attack, a group of 50 people comes and vandalizes. That's a law and order problem. We are doctors. We are not trained in using arms and mob management. That is not something that we are good at. If you are facing a mob attack, run for your life. If you are dealing with a situation of people intoxicated and under the influence of alcohol or other substances, that's a law and order problem. So please understand that we are doctors. We are not trained and equipped to deal with law and order problems. But we definitely can prevent a lot of anger escalating into a law and order problem in our day-to-day life. So what exactly is anger? We all will agree anger is an emotion. It's a negative emotion. Also, we need to understand that it consumes a lot of energy, and nobody likes to expend energy like that. When was the last time you got up from bed and decided, oh, I haven't been angry for a long time, today I'm going to get angry? Nobody plans to get angry. Nobody wants to get angry. It is such a draining emotion. But our day-to-day stress, it builds up and sometimes it bursts forth. Remember, patients and families don't come to us because they want to come to us. Hospital is not a picnic spot. It is not a leisure center. People come there because they are sick. They are suffering. They are not well. They are ill. That is what brings them to us. You would never want to come. You would never want to go to a hospital if it was not your workplace. We never want to get sick. So the starting point itself is negative. That people are sick, they are not well. And on top of that, how they are treated in the hospital, just it is the total opposite of how people are treated in a hotel or a resort. There at every point in a resort or in a hotel, right from the door, right from the time you park your car, you are made to feel welcome. Everybody smiles at you, wishes you, and tries to be helpful. It's just the opposite in the hospital environment. Right from the time you enter, there might be security who may be rude. You cannot go there, you cannot go there, you have to go there, and that kind of thing. You may have to wait a long time at the reception and nobody bothers to smile at you. Nobody comes to ask anything of you. You just sit there. And all the while you are suffering or your loved one is suffering. And many a times, once you get a token and then you are waiting outside the doctor's OP, and then you see people who came after you getting into the doctor's room before you, then the anger really escalates, because anyway you are uncomfortable to begin with. And then as a doctor, you hear loud voices outside your door and you wonder what is happening. And then you hear banging and things crashing. Then you know there is trouble. So anger can quickly escalate and get out of control. And for that, we have to understand what feeds an anger. There are two sources of energy which will increase anger. One, any kind of confrontation with an angry person will increase anger and sustain anger. Confrontation examples: arguing with a person, or giving excuses or explanations, or sometimes with a very angry person with high high flame anger. Even apologizing may increase the anger. Another source of energy is ignoring the angry person. You turn away from the angry person. You don't, respond to the angry queries, questions of this angry person. That will also increase the anger. So if you there are two source of energy. One source of energy is confrontation, and second source of energy is ignoring the angry person. So both can increase the anger. So how do you deal with a person who is getting so angry and high pitched, high volume, abusive person? And there, just like any communication, your body language is of utmost importance. You just cannot be confronting the angry person, and you just cannot be ignoring the angry person. And we just mentioned what all goes into confrontation, what all goes into ignoring. Therefore, most important thing is body language. First and foremost, whenever you see an angry person, remember the angry person is seldom sitting in a relaxed posture and getting angry. There will be so much of adrenaline in the angry person's body that the angry person just cannot sit down. He or she would be either standing or moving around, pacing around, walking around. So whenever you are dealing with an angry person, you also stand up. Remember in our last session on body language, when you equalize the body position, it improves satisfaction. For an angry with when you're dealing with an angry person, when you stand up, you are, without saying verbally, your body is showing that I treat you as my equal. You are showing equality. And when you are standing, stand with a slight kyphosis, a slight bent of your spine forward, not too much, just a slight. And just keeping a hand in front will ensure that slight kyphosis. Because when we talked about body language last time, we showed about body posture. A slight bent forward posture shows I am here to listen to you. It is also showing respect to the person who is getting angry at you. And hand in front of you, when you show where your hands are, you're also conveying, I am not a threat to you. If you keep a hand behind, it may increase the anxiety of the person, because all of this is primitive psychology, because the whole idea of salute and handshake starts from the notion of showing that you don't have a hidden uh, arm, you don't have a hidden weapon in your hand. So not having a hidden weapon in your hand is showing friendly tendency. That is why handshake is like a show of friendship, or salute is a show that I don't have weapon in my hand. I come in peace. So keeping a hand where the angry person can see easily is also important in your body language. So all these factors are going to reduce the person's anger without you saying a word. Now come, let's focus on your face. Eye contact. When you do not make eye contact, it will appear you are ignoring the person. So when you make eye contact, it shows that I am giving you my full attention. It also shows that I am not scared of you. I am confident. Remember, when somebody is giving you attention, it gives satisfaction. Also, when you are in the presence of somebody who is very confident, it is not easy to sustain anger towards a confident person. So your face and your eye contact should show confidence, show that you're not scared, but it should not show arrogance. It should not show a haughty temperament. Then the person's anger will increase. So you should have calm face, eye contact, which shows that you are confident and you are actively listening to that person. So never smile when a person is getting angry, because that will increase the person's anger. So usually in communication, we say smile, professional smile. So only place where we say don't smile is when you're dealing with a angry person. And nodding of head, right? When somebody is talking, we encourage the person to talk. And how do we encourage? We make eye contact and we nod our head. And in the previous session, I also said make some encouraging sounds like okay. But with an angry person, don't make encouraging sound. Just make eye contact and nod the head. So that person may be giving you maybe abusing, maybe saying a lot of bad things, but you really have to be stupid to fall for that. Remember, this is smart work. What is the ultimate aim? The end result of this procedure is to get the patient, to get the angry person calm so that nobody gets hurt and no damage is done. So this is the most important part of how to deal with it. Your body language, standing position, posture, respectful posture, and hands where it can be easily seen, and your face, make eye contact, keep the face serious, and nod your head so that it helps the angry person ventilate, because anger is an emotion just like crying, and you need the person to ventilate it as fast as possible. So with this body posture, you are neither confronting nor ignoring the person. And gradually you will realize within a few seconds or within a minute or two, you will see that the person's anger starts falling. How do you know? The pitch of the sound, from high pitch, it gets to normal pitch. The volume, from high volume, it comes to normal volume. And the abusive content in the person's ventilation comes down. The person is still getting angry, but not so much abusive. And once the high anger, the high flame is being brought to simmering anger, not very severe anger, at this point of time, for the first time, you can now open your mouth and say that I want to know more about this. Can we sit down somewhere and talk? So this is the point where you will invite the person to sit down and talk. And basically you are conveying, I want to know more about this. You haven't had enough, ye dil mange more. So you tell this person, I want to know more about this. And now you can sit somewhere, because all this while this display of anger may have been in a public space. So now you have reduce the anger to a simmering anger, and now you can take this person to sit and talk in a private place, so that the rest of the area, the public area, now can work like normal. So you take this person to a more private area, where now you sit down, bend slightly forward. Now keep your hand on the table so that this person can still see your hands, and make eye contact. Don't smile. Continue nodding the head while this person talks about all the problems he or she has been facing. Basically, in short, what you are doing, you are allowing ventilation of emotion. Remember, it is not a waste of time. It is a well-acknowledged therapy. Allowing ventilation of emotion, whether somebody is crying or angry, it's a very, very simple skill to master. Once the person has said everything, Usually what happens is they feel so guilty. In my case, I've had a couple of occasions where they apologize to me for getting angry. But it's not necessary that has to happen all the time. But allowing, the basic trick of managing anger is allowing the person to ventilate. So there is a way where you will safely allow this person to ventilate without causing any damage to anybody, including himself or us or to the property that we are in. If there is the problem, has a problem has been identified and you have a solution, offer the solution. Offer an apology only if it is merited. Don't give an apology for the sake of an apology. An insincere apology is easily understood, and this will create a bad taste in the person who has calmed down, or it may even trigger still more anger. So never apologize for the sake of it. If at all you apologize, it has to be real apology. It should come from your heart. An example: thank you for bringing this to our notice. We are very sorry you had to experience this. So here is a way of ending it by offering an apology. Another way of doing it without an apology, if it is not merited, don't have to apologize. Thank you for bringing this to our notice. This is what we are going to do. So you can explain what you're going to do so that something like this doesn't happen again. The last slide, take home points. When it comes to collusion, listen to the family to manage collusion. You have to earn the trust of the family, and then they will start listening to you. So conversion is very difficult. Among the three things that we talked today, collusion is perhaps the most difficult communication skills that one can master. And even then, you will never have 100% conversion rates. For people who are doing this for many years, we all face failures now and then. When it comes to communicating bad news, remember, your role is only as a facilitator of information. The patient decides whether they want to know or not. And if they want to know, they decide how much they want to know. You are just going to facilitate transfer of information. And remember, whether it is crying or anger, ventilation of emotion is a therapy. It is never a waste of time. And anger management is nothing but a non-confrontational active ventilation of emotion. And it is among the three, it is the easiest of the skill to master. With that, I stop. Sorry for the inconvenience in between, and we kind of exceeded our time limit. So I stop here and I'm open to questions. Over to
Thank
you.
you, Dr. Biju. Thank you so much for covering most important aspects in communication, that too in difficult communication. So we'll wait for some questions or some sharing from the participant side. So there's a question in the chat about legal aspect of not disclosing.
In our country, our socio-cultural setup is as such that it's the family that brings the patient to us. It's never the patient who comes to us, right? So that's why in our culture, the patient's autonomy, even though it is there, it is really subservient to the will of the family. So unlike some countries where you can be sued for telling the family without the permission of the patient, in our country, it is unlikely to happen. I hope that answers the question.
Yeah. Any other question that you wanted to ask?
I guess when you were attending the last session, when we talked about the basics, many of you had questions. If today's session answered those things, the questions in your mind, then I guess we are not likely to have much questions today. Or if this triggered more questions, then probably we just have to wait and see more sessions. If you're running short of time, Sridevi, probably we can get on with the session, and
Yeah.
maybe people
Yes, yes.
can put in their questions in the chat box,
Sure, sure.
and maybe we can deal with it all together in the end.
So there is already one question, and after that we'll pick up the presentation. Can we use professional counseling?
Hey, this session is about we all becoming professional counselors, irrespective of the primary work that we do. Basically, we learned active listening skills. We learned how to communicate truth. We learned how to deal with family who is scared of the truth, and we also dealt with how to deal with an angry patient. I mean, yeah, we are half counselors, professional counselors already. Of course, if you have the luxury of uh, you know uh, trained professional counselors as part of your team, why not? You know, moreover, communication skills is a team sport. It cannot be one person's burden. It cannot be one person's cross to bear. It's a team sport. Every person in your team. That means in your hospital, right from the security guard to the MD or the CEO of your hospital. Everybody should be good communicators. And if you, these two sessions have sensitized you to the importance of communication skills, and if you're in a position to make a change in your institution, get everybody trained. And I'm sure Palim India, definitely, I will be very happy to participate in any communication skills enhancement program in your respective institutions. You know, communication is always a team sport. We have to distribute this skill across the board so that just it's not a burden of one or two people.
And I think many times they do ask medical doubts, which sometimes the counselor may not be able to handle, and they very commonly trust the treating doctor. They want to hear these from the doctor than from another person in the team.
True,
So they
true.
might ask questions related to treatment, then the counselor will be kind of inadequate to answer those questions. Then they have to call in the doctor to that picture.
Yeah, true. I
Uh,
agree. I agree.
Thank you, Dr. Biju. We'll start the case presentation and take a few questions after that. Rajlakshmi?
Yes, ma'am. Dr. Uma, can I share the screen for you?
Yeah, sure. Yeah, can I start?
Yes, ma'am.
Yeah. So, good evening. That was a very wonderful session. In fact, I faced an angry patient today and I was wishing I had this anger management class yesterday. So, with that, I'll start with my case presentation. This is a case which really upset me, and that's why I wanted to bring it to this forum and discuss it. So, how do I advance the slides? Okay, fine. So, this patient I am presenting is a 48-year-old female who was diagnosed with post-COVID pneumonia during the first wave in October 2020. She had uncontrolled diabetes, hypertension, hypothyroidism, and also was a severe OSA. So the next slide, yeah. So in the presenting complaints, she had 2 months history of persistent dry cough after discharge from the hospital with moderate COVID pneumonia, progressive breathlessness, loss of appetite and weight, and there were no symptoms to suggest a connective tissue disorder. So understandably, during the pandemic, we tend to think that this is a post-COVID sequel because back in 2020, none of us even knew what COVID is going to do to us. The next slide. So in the history of illness, this patient presented first with SARI-like symptoms in October 2020, was treated as moderate COVID pneumonia and discharged on steroids and dabigatran. And in December 2020, she had persistent cough with whitish sputum, loss of weight, and appetite. So, as is usual with any post-COVID patient, the doctor got a CT done, which showed necrotic mediastinal lymph nodes with scattered peripheral ground glass opacifications. She was treated with antibiotics and referred for further evaluation. So, this is the radiology. You can see that there is a huge mediastinal node which has laid the carina. There's a big lymph nodal mass there. Next. Yeah, the slide is not changing. Yeah, okay. So on examination, this patient was obese. Her vitals were normal. There was no peripheral lymphadenopathy, clubbing, pallor, or edema. Next. And yeah, CVS was normal. Essentially, the entire systemic exam was normal. Next slide. So a provisional diagnosis of post-COVID status, and in view of the mediastinal nodes, we had thought of, the doctor outside had thought of TB or sarcoidosis, was referred to us for a bowel and transbronchial needle aspiration. The bowel was negative for gene expert. It showed lymphocyte predominance with 165 cells. Next. However, when we did the transbronchial needle aspiration was examined under the microscope, the histopathology showed a fibrinopurulent exudate with atypical cells, which was suspicious for a carcinoma. This is when the alarm bells began to ring. Next. So the further steps, as no discernible pulmonary lesion was seen, and we got a diagnosis of malignancy, a PET CT was done, which was indicated, which showed increased metabolic activity in the carinal nodes with a right lower lobe lung mass, which had not been seen on the CT, hepatic and vertebral metastasis as well. There was no endobronchial extension, so she was not amenable for transthoracic biopsy. So we went ahead with an open lung biopsy after counseling the patient. Mediastinal lymph nodes were also biopsied, which showed previous slide, which showed metastatic adenocarcinoma arising from the lung. Next slide. Yeah. So, and when we did a mutation analysis, we found that this patient was adult lymphoma kinase or ALK positive pulmonary adenocarcinoma with mediastinal lymph node metastasis. This is a very nice diagnosis for the treating physician, but the patient's problems had just begun. Next slide. So the issues we faced here was, as I've told you earlier, this was a patient who already had multiple comorbidities. She was OSA, she was diabetic, she was already on treatment. She had a recent COVID pneumonia and also now an additional diagnosis of metastatic adenocarcinoma. Next. So the issues we really faced was breaking the bad news. We had also gone in doing the procedure thinking that it's mostly post-COVID immunosuppression, TB got activated or whether it was sarcoid, but we had a very tough time breaking the bad news. The family had significant financial constraints because she was hit with COVID at a time when we knew nothing about the disease, so a lot of money had been spent. She was a single parent, had a young family, and she was financially dependent on a sibling. Targeted therapy, as we know, was possible because she was ALK positive. We could have given her a biologic agent, but they could not afford targeted therapy at this time. She was not fit for chemotherapy. Next slide. So the psychosocial aspects which we encountered was there was a complete lack of a support system. There was a minus daughter who was on the threshold of joining college. The patient didn't have a spouse, only a sibling was supporting, as I mentioned earlier. There were financial constraints as well. There was a recent drain due to COVID plus cost of treating comorbidities, and targeted therapy in a non-government setting is lakhs per month, which they just could not afford. And the psychological aspects were we had a very tough time ourselves accepting the diagnosis and then explaining that to the patient that she's developed a cancer within 6 months of COVID. Next. So the medications, she could not afford biologics. She was offered chemotherapy with due precautions because she was just out of a big infection. They were not ready to accept systemic side effects and repeated hospitalizations, which chemo could have caused if had she not tolerated it. Next. So palliative care reference was given because she also had pain. There were two reasons for palliative reference. One is the coping with the illness and the diagnosis, which came as a shock to us itself, and also for them to discuss treatment options like how Dr. Biju was discussing today, closure, reinforcing relationships. I mean, getting the whole family to accept her diagnosis. We felt not inadequate to do this, so we wanted palliative also to pitch in, and in our hospital, we usually have a group discussion with the palliative care physician. We go back and forth, but the patient's family was reluctant to take a consult because in their parlance, palliative care is equal to end of life care. So they didn't want to take a consult. They wanted to go elsewhere. She was discharged with the regular medications, and we didn't hear from her for quite some time. Next slide. So after 1 year of absence, I was pleasantly surprised when she walked into my OPD a couple of months ago and narrated what happened. The next of kin had withdrawn financial support after discharge. She tried a brief stint of a biologic with the remaining resources, and her daughter ran from pillar to post and managed to arrange a lifetime free supply of crizotinib after a denial phase lasting nearly 6 months when the patient was only on pain relief medication and monthly zoledronate. She came back to us with backache and anxiety about the illness. So it had really taken her a year plus a few months to understand that she was terminally ill. At this time, with so much of pain and so much of anxiety, she did agree to consult the palliative care physician. At present, her daughter juggles time between taking care of her mother and studying in an evening college because she cannot join a regular college due to the mother's illness. Next slide. So the main concern here, which again, the previous speaker, Dr. Biju, has elucidated very clearly, is we had issues with breaking bad news and fostering acceptance of illness in an already sick patient. We had issues with counseling family members. The daughter had just attained majority. She could not understand the illness of the patient. And the biggest problem we faced was convincing the family that palliative care is not only for end of life, but also for symptomatic relief, psychological benefits, counseling, and for planning. Next. Yeah, so the summary here is, I know it's getting a bit repetitive. For a clinician, it's difficult for me to deal with abstract topics. So this was a middle-aged lady with multiple comorbidities, metastatic lung cancer, poor family support system. And the general feeling I honestly had when the patient came back to me was that it was only fate and efforts by her daughter that steered her towards the appropriate treatment. I generally felt I could have done better when the diagnosis was made and probably could have done something else. Next. So these are the discussion points I thought could be taken up. Communicating to a patient who's already sick, formulating the treatment plan, and probably a group counseling by the treating physician and palliative care physician for effective care delivery. I think that's the last slide. Yeah, thank you.
Thank you, Dr. Uma. Maybe I'll like, as we have had a very in-depth session on how to communicate with the patient about this life-threatening illness, I would like to hear from the participants, like what all things you remember from what Dr. Biju said earlier about communicating the bad news, and how you plan to go ahead with this when you have the similar situation. So I like participants to come up with their suggestions, either by unmuting. Anyone? I think today everyone became so inactive. Usually there will be a lot of questions.
I have a question. In a situation like this, when the patient is alone with a younger a daughter who's not able to make a decision, and that poor girl has nobody else other than the mother to fall back on. In those situations, how well would all this, because the communication skills have to be probably at Dr. Biju's level, our level, we head nowhere. So we find it really difficult to counsel such people, especially when things are not going very well.
Hello. Like in some centers, they will have a psychology team or social worker team attached to the some places. For example, like Cancer Institute Adyar has an extensive psycho-oncology unit. So every place may not have a psycho-oncology unit, but there'll be a social care or a social element part available in some hospitals. So they can be contacted, or there are some private or teams like that available whom can be contacted for some support like this. There are many such organizations and things available. So maybe we may not know. So getting in touch, see, there will be social teams available in many cities or things like that. So keeping a contact with them may come handy, because financial thing, every hospital may not be able to help. So these type of organizations are there who can be contacted for, see, for example, all I'm telling is like same, even for getting some, see, for this matter, this lady's daughter, some support with her college. So some financial support comes in that. So then even the brother might suggest something, he may help. So going an extra mile to find out these options will come handy in overall patient care.
Dr. Priya, you were telling something else?
No. This is like the communication and convincing them about the whole process. Because like Dr. Biju said, the moment we start and tell them a bad news, they tend to take a second opinion, third opinion, and go on till they've exhausted whatever little resource they have, and emotionally and financially, and then come back. So this we've seen with cancers, we've seen more with chronic lung diseases, where probably it could have been a bit extended, or something could have been done to delay the inevitable. So at that stage, counseling becomes a very big task.
Dr. Biju, what would you, how will you respond to that?
I hear a lot of angst in Dr. Priya's voice. Please understand that we cannot possibly, have solutions for all the problems in the world. It is just not possible. The only thing in our hand is what we can do from our side. So you just mentioned, I heard that, we can't probably do counseling as Dr. Biju does. I mean, Dr. Biju also started somewhere, right? So I'm here taking a class. I didn't start by taking a class. I started by attending a class, and then, took baby steps, trying to, deal with the situations. I made plenty of mistakes. The only thing that I'm saying is that just like we make a lot of mistakes in our clinical day-to-day life, and with experience we learn and we get better, same thing with the communication skills or counseling skills or whatever you want to say. If you have resource, as Dr. Radha from Adayar said, like not every center may have that kind of resources, or maybe even the inclination that Adayar has to have, social workers and psycho-oncology support services. So make do with what we have. I mean, each one, if we make an effort, of course we will fail. We cannot, correct all the problems in the world. But if you have done your part, if you have made a sincere effort to the best of your ability, and then the patient goes for second opinion, third opinion, fourth opinion, doesn't matter. You can go home and have a good sleep knowing that you did the best according to your ability. Then it is for the individual patient and family. They have their autonomy. They will do whatever they want. That is definitely not in our hands. That is not in anybody's hands, irrespective of your communication skills. So do the best, and there is no shame in failing. The only shame is in not trying. And the more you try, things will get better and better. So understanding the angst in your voice coming from a heart in the right place. Please remember, we all should know how much we can lift, and then just do that. I don't know whether that make any sense. Did I go into metaphysics or something like that?
No, it made sense. Thank you.
All right, thank you.
Thank you, Dr. Biju. Maybe as Dr. Radha is mentioning, you have answered all the queries. That's why people don't have any questions this time. Are there any other questions or comments that you want to share before we wind up today's session? I think you always overshoot time, but this time we managed to at least 5 minutes. Thank you, Dr. Biju, and thank you, Dr. Uma, for the wonderful case presentation. And